Post-Pancreatectomy Haemorrhage. Among the major complications following Pancreaticoduodenectomy, hemorrhage is the least frequent, yet it carries the highest case fatality and often the most abrupt clinical deterioration. Over the next 15 to 20 minutes, I will set out a structured approach to its diagnosis and management organized around two axes and appraised throughout by the level of underlying evidence. First, the burden. Clinically significant post-pancreatectomy hemorrhage complicates approximately 3 to 10% of pancreaticoduodenectomies, rising towards 30% if every hemoglobin decrement meeting the ISGPS definition is included. Its significance lies in the case fatality. Hemorrhage accounts for between 10 to 38% of all post-pancreatectomy deaths and confers a greater than 6-fold increase in mortality. In a series exceeding 2,500 patients, in-hospital mortality was approximately 25% among those who bled against 4% among those who did not. This is therefore a low incidence, high lethality complication, the archetype of an event demanding a protocolized response. The organizing principle is that post-pancreatectomy hemorrhage is not a single entity. An early hemorrhage within hours of operation and a delayed arterial hemorrhage on the 14th postoperative day differ in etiology, in pathophysiology, and in management, and their mortality differs by an order of magnitude. Two questions therefore precede all others. First, the time of onset, early or delayed. Second, the location, intraluminal or extraluminal. These two axes, rather than the absolute volume of blood lost, determine the first appropriate intervention. These axes are codified in the ISGPS consensus definition of 2007, which grades hemorrhage on three parameters. First, time of onset. Early hemorrhage occurs within 24 hours of the end of the index operation. Delayed hemorrhage thereafter. Second is the location. Intraluminal into the gastrointestinal tract or extraluminal into the peritoneal cavity. Third is the severity. Mild, high hemoglobin fall below 3 grams per deciliter without compromise, or severe defined by a greater decrement, hemodynamic instability, or the requirement for transfusion or invasive intervention. These parameters combine into three grades. Grade A, early and mild. The patient is stable, management is observation and imaging without alteration of the clinical course. Grade B, either early and severe or delayed and mild, requires transfusion, angiography or endoscopy, and intermediate or intensive care. Grade C, delayed and severe, is life-threatening and mandates angiographic or operative intervention with intensive care. Critically, grade correlates with mortality. The classification is therefore prognostic and not merely descriptive. Consider each axis in turn. Early hemorrhage within 24 hours reflects a technical or hemostatic failure, inadequate intraoperative hemostasis, a displayed ligature, or a coagulopathy following massive transfusion. The operative field is not yet inflamed, and in the hemodynamically unstable patient, the appropriate response is prompt re-exploration with suture ligation of the bleeding point. Endovascular and endoscopic measures are secondary in this setting. Delayed hemorrhage is a distinct pathophysiological entity. Occurring typically between the 5th and the 15th postoperative days, it arises from erosion, activated pancreatic enzymes, and intraabdominal collection, or sepsis, degrading the wall of a skeletonized periarterial surface, producing a pseudoaneurysm or free arterial rupture. Clinically, relevant postoperative pancreatic fistula is the dominant antecedent implicated in up to 80% of cases. It is this mechanism that justifies regarding any delayed hemorrhage, however minor in presentation, as an impending catastrophic event. The second axis dictates the diagnostic and therapeutic instrument. Intraluminal hemorrhage manifests through the gastrointestinal tract via the nasogastric tube, has hematemesis or as melena, and its sources are in principle endoscopically accessible. Extraluminal hemorrhage presents as sanguineous drain output, abdominal distension, or unexplained hemodynamic instability. Its sources are arterial or venous and are addressed angiographically or operatively, not endoscopically. The pseudoaneurysm is the important exception. It might rupture into either compartment. Risk stratification is dominated by a single factor: clinical relevant postoperative pancreatic fistula, ISGPS grade B or C. Contributory factors include a soft pancreatic texture and a small non-dilated main pancreatic duct, both predisposing to fistula, together with extended lymphadenectomy and vascular skeletonization, concomitant venous or arterial resection, and biliary leak or intra-abdominal sepsis. A fibrotic gland is conversely protective. In practical terms, the prevention of hemorrhage is largely the prevention and timely drainage of fistula. Turning to the anatomical sources, on the extraluminal arterial side, the gastroduodenal artery stump is the prototypical culprit, skeletonized at the operation and lying in the trajectory of any anastomotic leak, with hemorrhage at a median of approximately 15 days. The classical hierarchy proceeds from the gastroduodenal stump to the common and left hepatic arteries, the splenic artery, and superior mesenteric branches. This gastroduodenal centric teaching warrants a contemporary qualification. In the largest modern single institution series, over 3,000 pancreaticoduodenectomies reported in JAMA surgery, in 2024, the gastroduodenal artery accounted for only approximately 1/6 of primary bleeds. More than half rose from other sites and a quarter were angiographically occult. The authors explicitly caution against routine prophylactic embolization of an uninvolved gastroduodenal stump, given its attendant morbidity and rebleeding. The gastroduodenal artery is the single most important source, yet numerically the minority. On the intraluminal side, hemorrhage arises from the pancreaticoenteric suture line, the transected pancreatic surface, the biliary or gastroenteric anastomosis, a stress or marginal ulcer or hemobilia, and from a pseudoaneurysm eroding into the lumen. The pancreaticoenteric reconstruction itself modulates risk. A meta-analysis of 11 randomized control trials, level 1 evidence, demonstrates a significantly higher incidence of post-operative hemorrhage with pancreaticogastrostomy than with pancreaticojejunostomy, with an odds ratio of approximately 1.5. The mechanism is anatomical. The gastrostomy suture line and transected surface lie within the gastric lumen and therefore bleed intraluminally, which correspondingly renders them endoscopically accessible. Before management, a sign of singular importance, the sentinel bleed. It is defined as a minor self-limiting herald hemorrhage, a brief episode of blood from a drain or the nasogastric tube ceasing spontaneously with the patient remaining hemodynamically stable that precedes major hemorrhage. It represents the first contained leak of an evolving pseudoaneurysm and may precede exsanguinating hemorrhage by an interval of hours to some 10 days. Proposed operational criteria include an unexplained hemoglobin fall of at least 1.5 grams per deciliter or drain or nasogastric blood arresting without intervention. Frequently, the sentinel bleed is not a solitary event but an intermittent one. Recurrent minor episodes separated by quiescent intervals upon a background of preserved stability. This relapsing pattern is itself the warning. Each episode represents transient sealing and re-leak of an enlarging lesion. Its intermittency also accounts for the false negative CT angiogram. The lesion may not be extravasating at the instant of acquisition. Accordingly, in the series of Taine and colleagues, 23% proceeded to major hemorrhage despite a negative angiogram. Every sentinel or an intermittent bleed therefore mandates angiography. Diagnosis proceeds in parallel with resuscitation, large bore access, balanced transfusion, correction of coagulopathy. The pivotal determination is hemodynamic stability. In the stable patient, contrast enhanced CT angiography is the first line localizer with a sensitivity comparable to catheter angiography, while additionally delineating any collection and confirming portal venous patency prior to hepatic arterial intervention. In the unstable, non-resuscitable patient, imaging is foregone in favor of an immediate operative exploration. The management algorithm reduces to a single decision tree: early with instability, operative re-exploration; delayed with stability, CT angiography; then catheter angiography with therapy directed by location. Embolization or covered stent for an extraluminal arterial source; endoscopy for an intraluminal one. Instability at any point or failed embolization leads to operative intervention. The endovascular approach merits detailed consideration. Transarterial embolization with coils or a proximal and distal sandwich across a pseudoaneurysm achieves hemostasis in 82 to 100% of cases, with rebleeding in 7 to 30. The central difficulty concerns the hepatic artery. Occlusive embolization arrests hemorrhage but risks hepatic ischemia, infarction, abscess, and hepatic failure, whereas flow-preserving superselective embolization of the pseudoaneurysm alone carries a high rebleeding rate, indeed 100% in one 15-year series. The covered stent graft resolves this dilemma by excluding the pseudoaneurysm while preserving hepatic arterial flow. In a comparative cohort of 70 patients, covered stents were superior to embolization in in-hospital mortality, 0 versus 32%, in major hepatic complications, and in 1-year mortality. Where the anatomy permits, the covered stent is therefore the preferred modality for hepatic arterial hemorrhage, with portal venous patency confirmed before any arterial sacrifice is contemplated. Where angiography is negative but suspicion persists, empirical embolization improves hemostasis, though without a demonstrated mortality benefit. Endoscopy is indicated for intraluminal endoscopically accessible sources, anastomotic or ulcer-related hemorrhage, with reported success of approximately 90% for delayed grade B, but only 64% for grade C intraluminal bleed. Its principal hazard is the insufflation adjacent to a fresh pancreatico or bilioenteric anastomosis, and it is of limited yield for the arterial pseudoaneurysms predominating in severe delayed hemorrhage. Operative management is indicated for early severe hemorrhage, for hemodynamic instability irrespective of timing, and for failed or unavailable angiography. In the largest surgical series, relaparotomy was employed in 69% as a primary intervention in 40 and as salvage after failed non-operative management in a further 31. The operation follows a defined sequence: hemostatic control first, and only thereafter a decision regarding the anastomosis and remanent alone. In that series, nearly 80% were controlled by local suture ligation alone. The eroded hepatic artery within an infective field is the most demanding scenario. Endovascular control where feasible is preferable. Pooled data favor it over surgery, with mortality of approximately 21 versus 43%. Where arterial ligation is unavoidable, the liver commonly survives on a collateral flow, but ischemic complications are frequent, and interposition reconstruction is considered when a proximal hepatic artery is sacrificed without collateralization. To the reconstruction questions specifically, for hemorrhage at a pancreaticogastrostomy, the stomach affords direct transluminal access. An anterior gastrotomy exposes the posterior anastomosis, permitting the bleeding suture line or transected surface to be oversewn under direct vision from within the lumen, with subsequent closure of the gastrotomy. Takedown is reserved for frank anastomotic disruption or uncontrollable arterial hemorrhage. For hemorrhage at a pancreaticoduodenectomy, management escalates in defined steps. The jejunal limb is opened via an enterotomy and the suture line oversewn under direct vision. Should the anastomosis be disrupted, it is taken down, at which point the reconstructive decision is governed by the state of the remnant. Here, the governing principle is pancreatic preservation wherever the remnant is salvageable. The options comprise a redo pancreaticoduodenectomy, conversion to a pancreaticogastrostomy, or an external varsingostomy, closure of the jejunal limb with externalization of the pancreatic duct, and deferred reconstruction. A technique called bridge stent technique can also be applied in certain scenarios. In a grade C fistula cohort, external varsingostomy carried an in-hospital mortality of 15% and permitted elective reanastomosis in 63% of survivors. The multicenter evidence favors pancreas-preserving procedures over completion pancreatectomy with an adjusted odds ratio for death of approximately 2.5 against the later. Completion pancreatectomy, that is the excision of the remnant, is the procedure of last resort reserved for uncontrollable or unsalvageable case. Its cost must be understood. Performed for hemorrhage, 30-day mortality approximates 34% and 90-day mortality 46%, with a systematic review mortality of 44%. The survivor is committed to brittle diabetes and a lifelong exocrine insufficiency. It is life-saving where no alternative exists, which is precisely why every pancreas-preserving option is first exhausted. With respect to outcome, overall mortality approximates 16%, concentrated within the delayed severe grade C bleeds at 40 to 50. The dominant prognostic determinant is not the hemorrhage per se, but the associated fistula, a mortality of 38% in its presence against 2% in its absence. Modality tracks stability. Image-guided control approximately halves mortality relative to surgery, although this comparison is confounded by the indication. Prevention follows from mechanism. As delayed hemorrhage represents erosion of a vessel by a leak, the two levers are reduction of the leak and protection of the vessel. Interposition of the round ligament over the gastroduodenal stem or hepatic artery reduces erosive hemorrhage. Grade B or grade C hemorrhage from 6 versus 13% in one comparative series. Fistula mitigation remains the principal preventive strategy. A necessary appraisal. The ISGPS definition is a reporting standard, not a management guideline. There exists no graded, society-endorsed treatment algorithm, and the management literature is accordingly observational. Oxford CEBM level 2 to 4. The apparent superiority of angiography over surgery is confounded by the indication, the unstable being triage to operation. So, the severity criteria rests on surrogates, hemoglobin decrement and transfusion susceptible to dilution. The 24-hour threshold is arbitrary, and the strongest operative question rests on small single center series. These are the appropriate caveats to hold. In summary, of evidential strength, the pancreaticogastrostomy versus jejunostomy hemorrhage risk rests on level 1 evidence, the angiography first strategy and the pancreas preserving preference on level 2 to 3 cohort data, and the operative techniques for anastomotic hemorrhage largely on level 3 to 4 series. The recommendations are clinically sound, but with few exceptions not of high evidential grade. In synthesis, 6 principles to retain. First, the entity is dual. Establish the timing before all else. Second, a sentinel or intermittent bleed is an emergency, not reassurance, and mandates angiography irrespective of a negative study. Third, therapy follows location. Intraluminal to endoscopy, extraluminal to angiography, instability to operation. Fourth, for hepatic arterial hemorrhage, favor the flow preserving covered stent. Fifth, preserve the pancreatic remnant. Completion pancreatectomy is the last resort. And sixth, the fistula is the through line. Its prevention is the prevention of hemorrhage. That constitutes a contemporary evidence-based approach to post-pancreatectomy hemorrhage, from the literature to the bedside. I thank you for your attention.